It's my great pleasure to introduce another patient advocate, Josh Mailman. He's a technology entrepreneur with an MBA from UCLA, and he's the president of the NorCal CarciNET Community. But I would like to give a personal appreciation for the work that he has done as Chief Operating Officer of the World Association of Molecular and Radionuclide Therapy. He's a pillar of that organisation, and he is making it possible for us to globalise these theranostic treatments. Josh, thank you.
Thank you. So first of all, since we're supposed to be tweeting, let's do this. Everyone smile. We all good? Oh, the lights are a little bright up here. All right, we're going to tweet out all the people who are watching. Michael, a few weeks ago, or maybe a month ago, gave me a topic for today. And it's morphed a few times in what we were going to call it, but I'll call it the RCT challenge, because it's really, we're here at the 20th anniversary of PRRT, and we've come a long way, but we still don't have a drug that's available for people. And my own personal story, which I'll talk about a little bit in a second, but without having the individualized, single-center trials that were available, I didn't have time to wait for an RCT. And that was one of the questions, is how do we look at this? But first, I want to take a thank you. This is actually looking, Rod was kind enough to take me on a tour on Friday of the wonderful cancer center. This is a look from the top floor looking down at the city. And all the views of the cancer center really look out, so patients have great access to very calming views as they're getting treated. It's really beautiful. I'd also like to thank the organizers, I'm one of them too, for having me come speak, and all the previous organizers, because patients have been part of the Theranostics World Congress since we started it in 2011. That's how I got involved in nuclear medicine and actually working with societies. The one in 2013 was key to helping the regulatory agents, the FDA, come and listen to patients express their frustration with some of the issues on how long it took to get approvals done. So who am I? My personal story, many of you know it since you've heard me speak before. I'm now 9 years plus as a journey as a patient, 2007. I've had 4 treatments with PRRT over the years. I have set up informational websites on PRRT for patients who are interested in getting the treatment. We set it up a month before the first World Congress of Gallium-68 and PRRT, and since that day in 2011, where I thought it would be a couple hundred people who might look at it in a year, it has averaged 1,500 to 2,000 visitors a month. So there's real interest in the world, and that's been consistent. And I've been fortunate, and largely from my first Theranostics World Congress, of actually working with medical societies on patient advocacy education. I'm the inaugural chair of patient advocacy for the SNMI. I also sit on their Gallium-68 working group. I am a member of the NCI task force on NETs. Jonathan, I think, are you still on the task force? Yes, with Jonathan. I spend a lot of my time working with NETs as well, but as I am an N of 1, and I'm not a doctor for who's ever looking into this online. Much to the earlier point, quoting Tom Petty here, the waiting is the hardest part, especially when you know you're sick. Waiting 3 years for a treatment when you know you need it is ridiculously long. We've been waiting in the US for actually approval, and we think that we're alone. We think that we've actually, well, let me actually move on. But waiting is very hard, and I'll get to that in a second. We are 20 years since the first PRRT with Y90 and LU-177, the first PRRT here in Australia and in Europe. Thousands and probably tens of thousands of patients have been treated worldwide. We've had the IAEA guidelines written. We've had selective availability based on geography, and as of today, not an approval. Patients don't know that. I put out a Facebook survey to see where patients or what patients thought about approvals and what their thinking was. 76% of patients already think that PRT has been approved, mostly in Europe. Some of them just think it's specifically in Europe. Literally 8% or a little less actually think the first approval will come in the United States. Many of them think it's approved here already. And this was a patient quote who was responding to the actual survey itself. They've taken so much time, it will come so late for many of us. So I wanted to talk, really what Michael set me off thinking about is the dilemma of being a patient, of how challenging it is to sit here and wait for an RCT, go to an individualized type of program, try to get in somewhere and see what's going on. And that really, I put this up there because we all like choice, or we think we like choice, but as a patient, really, we'd like to have no choice. We'd like to know what our next step is, what we need to do. This whole concept of whether there should be 4 doses, should it be individualized, we want all you guys to figure that out. We don't want to think about that. We just want to show up and take a treatment. I've written a lot in various things. You can probably Google me. There is another Josh Mailman, so if you get a guy who's rich and does venture capitalist, it ain't me, okay? So don't come up with me for asking for large sums of money, but this was something I actually wrote. If you want to hear my whole journey, this was written up in ASCO, but there is really no course for this, so we have no clue. We come in as a patient, we're blind. We're not medical experts, and as been brought out, we're all different, and we really just want to be cured. And we can go through the arguments about whether there's cytotoxic treatments that are better or whether PRT is better. We're not in a great place to understand this. I got lucky, or not lucky. When I really looked at this, when Michael put me to think about this, I didn't have to make that decision. My decision tree looked like this. I progressed. I had a hugely large tumor in my pancreas, and 75% of my liver was completely filled with tumors. I had no options. I could do nothing because there was nothing approved and no trial that I could go on. This was 2008, before ProMed and before any of the new cytotoxics, and I was not a surgical candidate. I could do nothing, and to the person who has 2 years, I probably didn't have 2 years at the point. Or I could decide to go and find a PRT treatment. So my decision matrix was hugely simple. I mean, that was easy. This chart has been brought up before as a thing to say, now we have PRT on the chart. If I got this chart right now and I was a patient, if you take a look at all the issues here, it's do this or do this or do this or do that. That's not a simple decision matrix for a bunch of patients. We don't know what stands here. Working in the nuclear medicine community, I know where PRT fits in the decision matrix of where you would put that, but we work with oncology, we work with interventional radiology, we work with surgeons, and while you may put that forward, they may not. So I want to get back to the central point, the RCT challenge that George put up very interestingly, and actually did a lot of my presentation for me, so I've got less to do. 20 years of PRT. We've treated 1,000 patients, and we've extended countless numbers of lives, mine included. But it's not universally available, even though we've treated tens of thousands. These individual INDs that have allowed us to treat so many people were done without standardized protocols, without standardized data collection, and we've hindered acceptance. We saw the charts about how, these different studies showed different years of how many people had how much PFS or how much overall survival, but to your point, they were not done in a controlled fashion and in a way that they were standardized or harmonized so that we could have some amount of reporting to go to regulatory agencies and work with. So the only time I think I've ever seen this, although it shows up other places, is almost every nuclear medicine conference somewhere, so I'm the obligatory one who's going to throw this up there, but the crossing of the Valley of the Death. A lot of the times we listen to physicians who are treating now and really are treating without an RCT because you want to do something and you don't want to leave anyone in the Valley of the Death while we get between the translation from discovery to practice to actually policy. And so that's been the reason that we've wanted to treat people now and keep that in, even if we're not doing these standardized methods. But while we've treated so many, we've actually left more behind in 20 years in the Valley of Death because we didn't get it done. We didn't get out to an approval. We got here. Many centers, different protocols, different data collected. Challenges with retrospective data. When I got treated, I went to Europe. I went to Bad Berka to see Dr. Baum. I was pretty much told by US Oncology that, yeah, well, you don't really have many options, but we don't really trust the data. We haven't seen it. It's all over the place. It's different. But if that's what you want to do, you can do it. So by waiting this long, we left patients with really poor choices. So what did we do in the US when we finally had our first two new kind of theranostic agents, which were gallium-68? We did 2 INDs. They were different drugs. They were different peptides, different data collections, and different questions being answered. So with all that 15 years of history, we did the exact same thing. We didn't help the regulators get their job done. So part of my work with the gallium-68 working group over the years, and first of all, we did much arguments on peptides, but we spent the next 2 years actually harmonizing the INDs, even though they weren't different peptides. We settled on how the data would be collected. We settled on how, nomenclature would be used so that when this data come together, we could actually use it for something. So that all these patients going through all these different centers actually could get benefit for the regulators and for policies. So back to pros and cons. I mean, the pro of the RCT was really mentioned. It confirms research. Really, besides getting the regulatories, it gets oncology buy-in. I mean, this is really big. It gets us to approval, it gets us to reimbursement, and it gets us to greater access, even if it isn't the personalized dose we really think of. The cons is it's really expensive. Trial design may leave some untreated. We have, people who in the last trial could not cross over. It's not personalized. One of the questions that I wanted to ask you is the first set of speakers here talked about individual dosimetry or individual dosing with different numbers of rounds and different amounts. That's really hard to get through, regulatory approvals. How do we work? It's even more adaptive, and how do we understand that so we can move that forward and we can get to the point of what Dr. Hicks practices here, which is individualized medicine all the time with every patient. That's a hard RCT to do. How do we adapt for that? We have an additional challenge here, which we haven't brought up, but a lot of the agents, especially early, were not, that we talked about, weren't patentable. So we really didn't have any pharma come up and actually spend money on this, so we had just academic agencies that don't have it. You brought up one other interesting thing, that you hadn't seen any theranostics. In June of this year, I was at the FDA in front of the FDA imaging panel and presenting another set of slides, not too dissimilar. And we discussed that theranostics and different agents might come up that pair with different treatment. And that here I was talking to a bunch of people who did diagnostics, but no one from the therapy group. And how are we going to do this going forward when diagnostics and therapy are going to be combination together? And they didn't have an answer for that yet. We have to work that through. This is the second thing that always shows up at a nuclear medicine conference. It's the old parachute RCT that no one ever did an RCT with a placebo-controlled parachute. And that there's actually a real paper on this. It's referenced all the time. Anyone want to volunteer for the placebo arm? Just checking. So I thought about that because it really is true. I mean, we do no testing? It turns out we do. There is the National Parachute Test Center. So it turns out that you do, work on different designs and see if they're better. And that's really what we have to do. We have to iterate. We have to get the next version of PRT or whatever that we're doing, and that we do actually test and go forward because, but RCTs are really expensive, right? I was shocked when I finally learned, and I sat in a room, that just the record keeping, forget the drugs, forget the human time, forget all the things, it's 50 grand to just register a patient for a trial and track them for a regulatory agent. Add the cost of drugs, the control arm, I'm gonna go with 75K. For our population that we look at in the NCI task force, I think it's about for 50-50, depending on what you're looking for, it's about 200 people. That's a very costly thing to do every time you have a drug that you want to bring out. And so we have to figure out how to be adaptive and bring it, because this number is way too big. Our population is way too small to afford this. So that's the big idea. We need to move faster because 20 years is just way too long. Average drug to development is 10 years. This has been around long enough, even farther back for other forms of PRT. So we have to move faster because we need to not leave people waiting for 3 years because of that. So let's not repeat our past. We need to do I feel like I'm talking right after you, with small focused trials that bring new ideas to life. We need to get collaborative work on protocols with harmonized data collection and working towards registration that will let us treat the majority. I'm an N of 1, I got it, I needed to go find my treatment. But we need to not leave people in the valley of death, and we need to get the drugs approved so that we can get the drugs to, or get treatments to the majority of us, and now we also need to start proving the value and methods for personalized dose planning so that we can really then do the next level and really get this personalized. I was telling them about, the decisions and the dilemmas of a patient. This is someone whose flat I'm staying at while I'm in Melbourne, and he brought up the Alice in Wonderland quote of which way should I go from here? And that depends a great deal on where you want to get to. And I think that's the problem for patients is we don't really know where to go. We know we want cures, and you're the ones who need to tell us, and working with your oncology partners, where we really want to get to and where we really need to go. Because I'm looking at this, and even though we're in a nuclear medicine setting where I know where PRT sits, I know when I needed to be restaged and have retreatment earlier this year, I went through all of those different things and had discussions about all of them, and I have a real great benefit of knowing many of you in this crowd, so it was a little easier for me, but for the majority of the patients, this is an impossible chart to look at. This is my group. We're in Oakland, actually the East Bay, San Francisco Bay Area. We hold an annual conference of about 350 a year on neuroendocrine tumors for patients. This was us before a large run around Lake Merritt, and I thank you for your time.
Thank you very much, Josh. We're very, very grateful, and we're very privileged to have patients as articulate and as caring for their fellow sufferers, and they've really stimulated us to get this into the market worldwide. Thank you very much, Josh, and I'll close the session and thank all the speakers.